Thank you. It's so wonderful to see old friends and make new ones. And this conference is really outstanding. Thank you, Dr. Bashami, for the invitation. I have no disclosures regarding this topic. And the objectives for my discussion today, and hopefully with the panel discussion, I think a lot of questions will come up, is how we define after total neoadjuvant therapy our complete response, our partial response, or incomplete response to rectal cancer, locally advanced rectal cancer, understand the risks of organ preservation with a partial response, particularly that near complete response that we talk about, and then what do we have really to offer to our patients for treatment when that is the case. And everybody would agree locally advanced rectal cancer a treatment of locally advanced rectal cancer has come a long way since the very first proctectomy. We have differences now in an increased complexity, definitely better quality of treatment that we offer our patients, and it's very personalized, tailored to the individual after discussions of multidisciplinary tumor board. And you see that treatment will vary even with the same stage according to the individual when it comes to duration, sequence, timing, even omission of a lot of these multimodality therapies like with the Prospect trial. But when I talk about TNT, just briefly on the terminology, it was the revolutionary paradigm shift in care, where adjuvant chemotherapy becomes a treatment modality before surgery. And when we talk about total neoadjuvant treatment, it's really that those theoretical advantages that we thought that we'll establish did come true. We did see that we have improved overall distant metastasis rates are lower. We see that we can offer patients de-escalation of therapy. We see that we can close the diverting stoma sooner because of this addition of the chemotherapy arm before surgery. And when we talk about induction is when chemotherapy precedes chemoradiation and then surgery and consolidation after chemoradiation. And the two trials, I'm sorry, these are, it's the Rapido trial here. I think I made a change in that slide, but I did not upload. The Rapido trial and the Protege trial are the two that were mentioned before that clearly showed that TNT is the way to go when it comes to the management of locally advanced rectal cancer. With short course radiation therapy, this was a European trial, short course radiation therapy, 6 cycles of chemotherapy, Capox or Folfox to surgery, versus the standard arm, which was chemoradiation, surgery, and then chemotherapy. And chemotherapy, the adjuvant arm was 8 cycles, not 6 cycles. However, what you see here is that pathologic complete response was much higher in the experimental arm. This trial was published in Lancet in 2021, and then in 5 years, the 5 years results, these are the 3-year results. The 5-year results in 2023 start showing that local regional failure is a little bit higher, and a little bit higher with the experimental arm. But here, if you're being critical, here we have short course radiation therapy, no long course radiation therapy that is most likely what we'll use here in the United States. Operative complications, as a surgeon, we have not seen really differences, perioperative morbidity and mortality actually extending surgery, the time frame between the radiation to surgery, you have not seen really that significant changes, and overall survival was the same. And then with the Protege trial here, you see the sandwich of chemotherapy before and after. Clearly with more chemotherapy, you see the increase of pathological complete response. No surprise here, again, standardized that treatment of total neoadjuvant treatment that we now offer to all locally advanced rectal cancers for our patients. And then during the same time, we have here in the United States, the organ preservation trial. It was more than total neoadjuvant treatment. Here it was like, how much can I push the envelope and offer a TME-free survival to my patient when I see significant response after either induction or consolidation TNT. And really what we are finding, and we are still, I think this is the bucket now that we have to be very thoughtful and critical when we are judging, is those patients that we call near complete response. What you see here with the induction and the consolidation, the ones that had incomplete response, they will go to total mesorectal excision, versus the ones that did not. And that bucket, in particular this trial, became very large because they accepted a lot of that near complete response with a complete response, and they followed them. Overall, the way that they defined a complete response, incomplete response, and partial response or near complete response, you see here the pictures. On the very left of the screen, you see the complete response, that telangiectatic scar. When the colorectal surgeon does the DRE, you feel like normal mucosa, you do the endoscopy, and clearly you see no tumor whatsoever left. When you see an incomplete response, or what I would call a partial response, is when I start seeing a little bit of nodularity, irregularity, erythema. It's just not the flat scar that I would like to see after TNT. And of course, the incomplete response is visible gross tumor. So these are really the definitions of those responses after TNT in the OPERA trial, which again, their aim was to organ preserve, and they increased the middle bucket a little bit of the patients, tolerating a little bit more of what would be a complete clinical response. What also OPERA showed us is that the regrowth rates were higher with induction TNT versus consolidation TNT, and overall patients did a little bit better, meaning that they had less chances of receiving a total mesorectal excision. However, if you compare this trial with any other trial with TNT and regrowth rates, you'll see they're pretty significantly high. 36% of regrowth. As a physician, it's the discussion you bring up with the patient, is a high number in my book. And also, but when you see clinical complete response, when your patient asks what are the chances of developing distant metastasis, they're not nil. And it's not so much because I believe there is the regrowth that will cause the metastasis, and we can discuss that. But it's mostly the fact that sometimes we don't know the biology of the tumor. That's why there's a lot of studies still to be done of what really, even with complete response, I may see 13% chances of risk of having a distant metastasis. So this is really what OPERA taught us. And later, in 2024, when this paper came out, again, looking back at the long-term results, you see here local regrowth at 2 years with complete clinical response, no surprise, 20%. The near clinical response, 49%. Interesting enough, you see with the organ preservation was offered to the near complete responders, which means I'm not risk averse. Like I'm really willing, and if the patient is really hesitant to proceed with a total mesorectal excision, to watch and wait. And even in that group, surprisingly, you see 40% successfully was watched and wait and had an organ preservation. And it goes without saying, you would expect disease-free survival to be better with the complete responders. There was just a paper came out in March in DCR discussing like the response to TNT kind of predicts the biology of the tumor. I think Dr. Blake Cady very nicely said it, the biology of the tumor is the king, and we are just like working around it to address it. So with the disease-free survival, CCR 88%, with partial complete response 69%, and incomplete response with 56%. Not surprisingly, intuitively that makes sense. But really what it makes me think as a physician, where I need to start thinking what I define as near complete response. And what do I have really to define it is MRI. You heard very lovely here from Dr. Kashami, endoscopy and MRI. And in this actually article that was published in JCO in 2024, when you're trying to find and judge with what modalities you have, what is the true response, the true clinical response with the two modalities of endoscopy and MRI, you find out that really we're not doing that great. Definitely endoscopy outperforms MRI when I am to judge a complete clinical response. And what you see here in the accuracy, this is a bucket of patients that were near complete responders and complete responders. So together a 66% accuracy for a true response. And here is the bucket of patients that truly had complete clinical response. It's a little bit higher, 75%. But anytime when you judge the modalities that you have, you need to think of what patient population you included in that group. So if you include the group that was studied that were under the OPERA trial, again, what was the primary endpoint? Organ preservation. They were, let's say, less risk averse, and they included a lot of the near complete responders. So if I was more strict in my criteria, perhaps MRI and endoscopy would be much higher accuracy of how I define a complete clinical response. And of course, with this data, I mean, MCCN had no choice. They put it into, I mean, this is now standard guidelines offering TNT and offering watch and wait after a complete clinical response. But no one can truly define it so clearly. And there are many, many studies to show that there is that kind of range of what complete versus near complete may be. And I'll bring up a lot of patients of mine and of my partners, how we discuss them in multidisciplinary tumor board. So this paper actually came out a year ago in DCR discussing endoscopic now predictors. We know endoscopy outperforms MRI when it comes judging clinical response to TNT. And you find, we find out here what you see on the left side of the screen, the complete, response. I would say in my strict eyes, I would say that's complete response. And then the second picture, a lot of my partner may call that complete response. I will call it near complete response. In that paper, they defined it as near complete response. And of course, the grossly visible tumor that you see on the right of the screen. And when they did a post hoc analysis of that group of patients, of which are the two characteristics that can predict regrowth from endoscopy, you see here an ulceration and irregular mucosa was the two predictors when they took multiple variables. And this is a logistic regression, so this is a multivariable logistic regression model. So with that in mind, and what we know, what we've offered for surveillance. And this is where I think we have this blanket surveillance that we have like extrapolated from TNT and the OKRA trial, diffusion weighted MRI every 6 months, Flex 6 every 4 months for the first 3 years. In our institution, we tended to actually kind of rotate in a way that we give only an interval of 2 months in between. The CA and the CT is what has been now for years, decades followed. But is that enough? So I will start going into cases and what our discussions were in our multidisciplinary tumor board and what is our comfort level of how we define complete response versus near complete response after TNT. So the very first case is a 72-year-old gentleman with rectal cancer, recurrent prostate cancer. You see the cancer over here, and it has EMVI shown in MRI. Discussed in multidisciplinary tumor board and started TNT treatment. Received our preference is even with the MVI, we'll always do consolidation TNT in our institution, and this is the result, which is pretty remarkable. And what you see on the very first picture is that what I would call a near complete response. The MRI at the time, because it was concurrent, showed non-diffusion, like fibrosis, like really a very successful result, one would say. And you see it's in the first valve of Houston. You see where the dentate line is. So as a surgeon, I always think whenever I have a tumor, if I am to offer surgery, am I offering intestinal continuity as an option to the patient, or am I talking about a permanent stoma? And you see here this very nice response. So in my eyes, again, my partner in multidisciplinary tumor board will disagree. It's a near complete response. Biopsies were taken, and of course, fibrinous exudate. Nothing really that showed invested adenocarcinoma. Discussion with the patient, and the patient is willing to wait for a repeat Flex 6. Flex 6 you see here later in October. Again, some irregularity, some scarring, multiple biopsies, which is not what has been described in the original OKRA trial. Multiple biopsies not showing tumor, MRI again, not really indicating any disease. Not knowing, knowing that salvage surgery, and I should not call salvage because it's really curative intent, is really close to 90% of those patients, makes me comfortable to continue the discussion with the patient. And you see here, we continue the flexible sigmoidoscopy. We see the same kind of scar, and I added here what the biopsy showed, negative for malignancy. And I'll just fast forward. Now we're at 2024. And this image in anybody's eyes will say, oh, that looks so much better, that we have now complete response, worthwhile the wait. But my biopsy showed invasive adenocarcinoma and underwent a coloanal resection. So lesson, one patient, we move to the next. T3, an ugly tumor here, T3 and positive. And I have to say, this is extremely important every time we present a patient to know the initial staging. I practice in a place where multiple patients will come. It's a very big state. I'm in Oregon, very big rural state. They come with different clinical initial staging that needs to be repeated. If I have the opportunity, if the patients, we can make it work with insurances. Just to repeat the imaging, because it's extremely important to get to know if you're dealing with the tumors that there was in the Rapido trial. T4AB, EMV positive, N2 positive, versus what we have in the Prospect trial, which was a T3 and a T4, not positive, no disease. It's really knowing what beast we are dealing with. And in this particular tumor, you see here, the pictures are pretty telling of the MRI, receives TNT, and this is where we are. Gets a flexible sigmoidoscopy. You see the fibrosis, you see kind of the narrowing of the diameter, a little hyperplastic polyp there, sorry, the picture, not significant, not relative, clinically significant in this particular patient. Looks pretty good. We have the discussion of continuing, discussed in multidisciplinary tumor board, and we proceed. We proceed with another FLEX6, and this FLEX6 makes me feel nervous. I don't think this is purely what I would like to see. I thought it was looked a little bit better in the past. Here, I discuss it with the patient all this time, MRIs not showing or indicating regrowth, and we continue. And here we are on the January 2024, now evidence of local regrowth. I think the arrows show it, biopsy showing invasive adenocarcinoma and receiving surgery. Now, any surgeon in the audience will ask me how tough was the surgery, because we're talking about fibrosis, bleeding risk, and everything. And I have to say, in our hands, we have not seen significant differences. I would say, and we were able to do another colloidal, actually here, a TME colloidal operation for this individual. And then another one, even an uglier tumor here, as I say, the big and ugly with what I'm dealing, that involves the sphincter muscles. You do the endoscopy, and you start with TNT. And this patient also received consolidation. As I mentioned, consolidation TNT, very rarely will do induction, only like the MVI is so positive that we're so worried about micrometastatic disease. We may think of an induction TNT. But here we are, and this is the FLEX6 after end of treatment. MRI looks great. And here it is, again, irregular mucosa, a little bit of ulceration, makes me very nervous. I asked the patient to come back 1 month later. If you saw the surveillance guidelines for our institution, that's not really our surveillance guidelines, which also tells me one blanket does not fit all. And here, clearly you see tumor, this patient undergoes surgery. As I mentioned, I work in an institution that is the tertiary quaternary center for a very big state, and we receive patients that have received TNT on the outside, and I don't have even sometimes the initial, the very initial studies, imaging studies. But this patient came to me after she had received TNT for a very low rectal cancer, stage 3 and 1. And no MBI from what I got as a report. When she came to me because she didn't like the response she received from her local surgeon that, you know, I don't think you have a complete response, and we will need to do an ABR. And these are the images. I do the FLEX6, I see these images, and I say I definitely don't like what I see in the scar. Our MRI reads that not definite tumor. I said how comfortable this patient is waiting, and let's repeat the flexible sigmoidoscopy. I think she has a lot of radiation treatment effects. So we repeat the FLEX6 in 11 and 2 months later. And it looks similar, or I should say a little bit better. It makes me more optimistic that I may see a better response. We continue. This is more FLEX6 actually than I have pictures up here that happened before, but you start seeing this very white scar. and everything looks much smoother, and you're becoming hopeful, and you're saying, okay, maybe this is pretty good. MRI continues to be negative. You continue, as you see in the you see the pictures on the left, looks good. Continue. I do biopsies. Now again, the biopsies is, I say, the blind, how we pick up the leaves from a bush, and we may pick up the healthy leaves, and there are many dead leaves around. But anyway, so the biopsies, how critical they are, but reassured me, maybe not a little bit, and I had this discussion with the patient. The patient wants to continue to be observed. Of course, a patient who doesn't want to have an APR, and what you see 3 months later, even a better scar. And I'm like, oh, maybe this is going to be fine. This is going to go well. And we continue with flexible sigmoidoscopy and MRI, and here she comes a year later, 6/24, where I start seeing this very notable ulcer. And I take biopsies, and they come back as an invasive adenocarcinoma. I bring her back within like 3 weeks to repeat the biopsies, invasive adenocarcinoma, and she undergoes an APR. And this is the first time I see so much fibrosis. The tumor, it was pretty advanced locally, and so she underwent an APR, posterior vaginectomy, and reconstruction. Has done well, no distant metastases, but this is like what we're dealing with when we increase this bucket of what we call near complete response. And then, of course, you have this, T3C, mean to rectal neoplasm without an MBA, undergoes TNT, and those pictures never change. Flexic years 1, 2, and then I think I have 3 and 4, and I have a lot of patients now with those pictures as well. So what is my summary or my conclusion? We don't know what we don't know. We're learning a lot. I love the progress, but we need to be very careful and very honest with our patients and ourselves, as I say, as physicians. Consolidation type TNT definitely pushed the envelope. This is where we needed to go, and I think we're doing the right thing. However, we need to define uniform criteria of what we call complete responders versus partial responders. The philosophy of the physician and the institution here comes into play. How big that bucket would be, what is my goal, really, and what the modalities I have. I'm very excited with radiomics and everything I hear today, like where we're pushing the envelope, because this is the right thing for our patients, but I don't think we're there yet. And definitely with partial complete responders, high-risk features, ulcer nodularity. As you saw, my tachycardia and normal cardia, I was seeing all these flexics following my patients and where we need to be. And so there is much more to be done and learned, but an exciting time. And with that, I'm going to end here. Thank you.